Hello and welcome to Friday Chalk Talk. I'm Rachel Gage. I'm so happy you're here. And I am very thrilled to introduce Robert Kiltzman, MD. He's a professor of psychiatry at I'm going to say this incorrectly, but Gallegos College of Physicians and Surgeons, and the Joseph Mailman School of Public Health, and the director of the online and in-person bioethics masters and certificate programs at Columbia University. He's written in 180 scientific journal articles, 10 books, numerous chapters on critical issues in bioethics regarding doctor-patient relationships, communications, research, genetics, mental health, pandemics, and other areas. A few highlighted books I thought were fascinating were The Ethics Police, The Struggle to Make Human Research Safe, When Doctors Become Patients, In a House of Dreams and Glass, Becoming a Psychiatrist, and The Trembling Mountain, a personal account of Kuru, cannibals, and mad cow disease. I want to hear about that trip because that sounds fascinating in Papua New Guinea. Klitzman has received numerous awards for his work, including fellowships from Guggenheim Foundation, the Sage Foundation, Commonwealth Fund, Diamond Foundation, Hastings Center, and Rockefeller Foundation. He's been a gubernatorial appointee at the Empire State Stem Cell Commission, say that 3 times fast, and the Ethics Working Group for the HIV Prevention Trials Network, served on the U.S. Department of Defense Research Ethics Advisory Panel, as well as other prominent and noted appointments. So I want to give Robert all the time we can give him. We're very happy you're here. Want to hear everything you have to say. Thank you for being here, and please take the stage.
Well, thank you so much for the invitation to be here. Marty, Rachel, thank you so much. And thank you all of you for being here with us. And I see this as an interactive session, so please feel free to ask questions, and hopefully we'll have time to engage in dialogue and answer all the questions that you have. So I just wrote a book called Doctor, Will You Pray For Me? Medicine, Chaplains, and Healing the Whole Person is mentioned. That covers a number of issues that I think might be of interest to the group. And I thought I would start by talking about why I wrote the book, and it relates to New Guinea. So when I was deciding what I wanted to do with my life when I graduated college, I got a job working for the NIH, and they sent me to Papua New Guinea to study get ready for this, cannibalistic rituals that led to the spread of a brain disease that was called Kuru, that turned out to be the same as mad cow disease, which was not discovered till a few years later. And when someone died in the tribe, the women were bereaved, of course. They had no meat in their diet, the women, and so they would consume the person with their young children. And as one woman I interviewed said this way, I'll always have part of my mother inside of me. So this was Stone Age. They had no metal, no written language, etc. And I was struck by this. And they believed that the disease was actually caused by sorcery and could be cured by sorcery. And so they continued to practice the cannibalism. And when they believed that a sorcerer would take something that belongs to you and wrap it around a stone and bury it and cast a spell on it. And they dig up stones and say, see the stone, this is the stone that killed my mother. And I'd say, no, Kuru is caused by a little thing like an insect. And they said, well, show it to us. And I said, well, it's too small to see. You need a special machine. And they'd say, well, what does it look like? And I'd say, we don't know. And because we hadn't identified it. And they'd say, well, have you seen it? And I'd say, no. And they'd say, that's just magic. It's a stone that killed my mother. The stone. And they believed they could cure the disease. And I said, who have you cured? I met one of the shamans, and he said, all these people I cured. And then I said, is there anyone who you didn't cure? And he said, well, that guy there who was the one person that I had diagnosed with the disease. And I said, what's the treatment? And he said, well, for 2 weeks, you're not allowed to drink water or eat salt or touch a member of the opposite sex. And I give some herbs and I cast a spell. So I said, how come anyone got sick? And he said, very simple. They didn't follow the treatment. They were not good patients. And of course, when patients today in our hospitals don't get better, we often say the patient failed the treatment, not that the treatment failed the patient. So flash forward, I became a medical intern. And the first day I got a list of patients and met the first one, and lovely Japanese woman. And she was in her room cutting her grapefruit, complaining it wasn't fresh. And we had a nice chat. And I walked out in the hall, and my supervisor saw me, my resident. And he said, what have you been doing? And I said, I just spoke to Mrs. So-and-so. And he said, she's dead. Don't waste your time with the dead. I said, what do you mean she's dead? I just spoke with her. He went, she's dead. Don't waste your time. And I thought maybe there's two patients. And then I realized she was do not resuscitate, DNR. And in his mind, she was dead. Don't waste your time with her. And I felt, what island, what tribe have I landed on? In landed, I felt like I was back in New Guinea. And so I got interested in how we understand disease, what we do at the end of life, how we bereave, how we remember people who've died, what kind of beliefs we have about what's going to treat the patient or not treat the patient. And so I got interested in that. And then flash forward, unfortunately, on 9/11, my sister died. She worked in the World Trade Center, and she called her best friend at 8:30 in the morning, and then a plane hit and she died. And I had to register as with the FBI as a missing person. We had no body, but she was presumed dead. It was a terrible few weeks for my family and I. Uh, and then my body just gave out. I just wanted to lay under the sheets and didn't want to watch TV or listen to music or anything. And I thought I had the flu. And people said, no, these are symptoms of grief. And I said, no, no, I have the flu. And of course, they were right in the end. But I was surprised how it was a bodily experience. And even though I was a psychiatrist, I was surprised how much I didn't know what it was actually like. And a lot of doctors look down at patients who somaticize, who complain about back pain or various pains. But this is the way often depression and grief manifest themselves. These are biological phenomena. So I wrote a book called When Doctors Become Patients. I decided to do a study of doctors who became patients to see how they changed. So I interviewed 75 physicians who became patients, and they all said versions of the following. When I asked them, how has it been different for you being a doctor now, having now been a patient yourself? And they all said, well, patients used to say to me, Doc, would you pray for me? And I'd go, yeah, yeah, whatever. I'd poo-poo it. And then I became a patient and didn't know if I'd survive. And I suddenly realized how important these existential, spiritual, religious issues are, but I have no training to deal with them. I don't know what to do with them. One doctor said he was once wheeling a young boy into the operating room and was convinced the child would die. And the family at the last minute said, Doctor, would you stand here and pray with us? And the doctor thought, well, they're Catholic, I'm Jewish. Nah, he said, no. And he walked away. And afterwards, he said, that bothered me. I don't know what could I have said in response. And I said, well, you could have said, well, I'm happy to stand here with you, or I'm happy to be supportive or something. So I became interested in this. And of course, we also live in a time of immense polarization politically, but also religiously. And, 35% of America are evangelical Christians. A third of America is now agnostic or atheist or believes nothing in particular. So things are shifting. So I got interested in how patients deal with these issues at the end of life, how they deal with religious, spiritual, existential issues. And so I did research, conducting studies, and I ended up focusing to a large degree on hospital chaplains because I realized how crucial they are. But in many ways, I realized how they're unsung heroes. They do immense, important work, and yet, except for the area of palliative care and hospice, they're widely ignored in medical practice. And in medical school, we don't learn anything about who chaplains are, what they do. So I was really surprised and impressed by what they do and how they help patients at the end of life and other times, but they face huge challenges and that I thought were of note. So, for instance, they often play roles as mediators. So one chaplain, for instance, said that there was a young man who was dying and knew he was dying and said he wanted to be an organ donor. And he was soon brain dead. He had a progressive disease, and the family had said, okay, we'll donate his organs. And the surgeons, but they said, but we want to be there when he dies, when you unplug him, because at this point it was just heart and lung machines keeping him alive. We want to be there. And the surgeon said, absolutely not. This is going to be in the operating room. You'd have to gown up. We have to get the organs out very quickly. Otherwise, they're no good. The family will delay things. And the family, they were at loggerheads. The family was basically saying, well, then the hell with this. We're not going to donate his organs. And they were arguing back and forth. And the chaplain said, well, let me talk to everyone. And the chaplain got the surgeons to agree the family would come in for just 2 minutes into the operating room. They would gown up and then they would leave. So that's what happened. And when they were all there in the operating room, the chaplain said to the family, does he have a favorite? Did he have a favorite song? And the family said Amazing Grace. So they all sang Amazing Grace. The doctors and nurses joined in. everyone was soon crying, the doctors, the nurses, and then the family left. And the mother said to the chaplain, thank you so much. We got to sing my son into heaven. So that is, I think, a beautiful experience in a lot of ways, but that would not have happened if it weren't for the chaplain being there and negotiating things and mediating things. Similarly, at times, chaplains don't know what to expect with patients. So there was another chaplain went and uh, knocked on the door of a patient's room, said, I'm the chaplain. And the patient went like this and said, stop right there. You are anathema to me. My religion is CNN. I believe in the truth. I believe in facts. I believe in politics. And the chaplain was taken aback. Oh my God, well, okay. The next day, the chaplain thought, well, let me go back and try talking to the patient again. And the chaplain said, remember me? And the patient went, yeah. And the chaplain said, well, I understand your religion is CNN, but let's talk about what's going on politically today. What do you think? And they ended up having a great relationship. This was a lonely woman who had really no one else in her life, no other source of support. Uh, she was an atheist, but she was very lonely and was dying, and really appreciated the chaplain coming and talking to her. So, again, chaplains describe themselves as having a post-religious profession at this point, of being able to talk with patients across religious, spiritual views. And I think these are very valuable skills that, unfortunately, many of us in medicine and in healthcare don't have. We ignore this. We feel uncomfortable. Studies show that most doctors feel that religious, spiritual issues are important to patients, and they should spend more time as providers dealing with this, but they don't know how. They're uncomfortable. They say, well, I'm afraid the patient will get uncomfortable. But it turns out it's their own discomfort that's most strongly associated with their not speaking about these issues. Uh, and they often get medically useful information. So there was one patient who would call at 2 in the morning, the nursing station when in the hospital every night. He couldn't sleep. He was in pain. They'd try different pain meds. And the chaplain said, well, let me go talk to him. And the chaplain finally went and talked to him. And it turned out that he felt immense guilt that his mother had committed suicide when he was a boy, that this has troubled him, and he blames himself. And so the chaplain contacted the family, his siblings. He was the youngest sibling, who said, no, mom was depressed for decades, even before you were born. She had been hospitalized for depression. So again, and then he stopped calling the nursing station. So again, chaplains basically doing the only kind of psychotherapy in hospitals at this point. So the only person, if you're in hospital with a terrible disease, terminal illness, for instance, the only person to say, well, what's that like for you? How are you doing? Is the hospital chaplain. Psychiatrists are few and far between. When they do come, they just prescribe medication, often antipsychotic medication. Social workers could do a lot of this, but they're often having to spend their time just with discharge planning and arranging for, a bed in a rehab facility, et cetera. So the book goes into great stories and has insights to help all of us as providers, and also all of us as just people who have family members who are ill, or we ourselves may be ill, and how to sort of approach these issues now in 2024, with people having variety of views. One patient I interviewed said, I'm not religious, but I believe in the third law of thermodynamics, that energy is neither created nor destroyed in the universe. It just goes on. Again, a very sort of spiritual view. So I think people evolve with the need to have some sense of, if you will, symbolic immortality, of going on in some way, either through their children or through religion or through creative work or experiential transcendence, sort of drugs and sex and rock and roll, to feel that they're leaving this sort of mundane day-to-day existence, but that there's something larger than ourselves. And again, it could be, doesn't be religion. It could be people get support from book clubs. They get support from gardening, from gardening clubs, from Harry Potter discussion groups, from yoga. But I think these are all important things in our lives that we in medicine ignore, or many of us in medicine, or many people in medicine ignore, and we need to pay more attention to them. So I could go on. I'm happy to talk more about the book and about research, the research I did and what I found, but I thought maybe I'll just stop there and see if people have any questions. Caitlin is a question.
Good.
Caitlin?
Yes, thank you so much. So I am a chaplain. I am a chaplain in a hospital in downtown Milwaukee. And I wondered if your research touched at all around the chaplains of providing care to staff. I think since COVID, that's been
Yeah, yeah, yeah,
such an incredible part of our work. And addressing things like moral injury, moral
yeah,
distress, creating ritual around communal grief.
yep. Thank you
Um,
for that. Yeah, I didn't
so
mean to cut you off. Sorry.
no, that's quite all right. So I'm just interested if you could share if that was an element of your research.
Yes, very much so. And thank you for bringing that up. As I said, there's lots and lots of issues here, and I just thought I'd mention a few of them in my sort of opening remarks, if you will. But absolutely, chaplains play crucial roles helping with moral injury with staff. And one thing that struck me is that a number of chaplains during the COVID pandemic invented things on their own, invented approaches, invented rituals on their own that turned out very helpful. And so I saw the book as an opportunity partly to sort of put these all, lay some of these out so other people can benefit from them. So one chaplain, for instance, said, during COVID, I started chocolate rounds. So, there's grand rounds and et cetera. So I would go around with a box of chocolate to staff and I would say, I'm doing chocolate rounds. Would you like a chocolate? And staff would invariably say, sure, I'd love a chocolate. And the chaplain would say, well, how are things going? What's going on? Well, we had 6 deaths last week and whatever it is. And the chaplain would support them. Another chaplain said during COVID, so many people were losing people in their own lives as well as patients that she created a wreath in the nursing station. And she had a stack of papers, and people would write the name of someone they had lost, either a family member, a patient, and put it on the wreath and would say something about it. And soon it was covered with these leaves. And at the end, she said, well, I guess I'll take it down. And people said, no, you have to leave this here. It's really a memorial for all of us. So again, I think on the other hand, there was pushback. So one chaplain said, well, the nurses were distressed. I want to speak with the nurses. So she asked the nursing supervisor, I'd like to have a kind of a meeting with the nurses, see how they're feeling. And the nursing supervisor said, absolutely not. They need to be on the floor. They can't afford the extra time. So the chaplain said, well, let me just try once and maybe you can come too. So she said, well, okay. So she went and the chaplain said, how are things going? And the nurses soon were all bursted into tears and were crying and said how hard it was and how helpful it was to have a chance to talk about it. And the nursing supervisor at the end said, please keep doing this. So again, a lot of chaplains, and this may resonate with your experience, often feel dissed or marginalized by doctors, by sometimes nurses, by hospital administrators, the hospital itself, but they do great work like this. And I think in many cases, chaplains have had an uphill battle in trying to help staff or getting permission or getting that recognized. So I think they're doing enormous good. I was struck how many are on their own developing different ways of doing that, that I think other chaplains would benefit from. In various ways with staff, but as well as with patients. And I think sharing that could be good. And I think also a number of chaplains have taken the book, for instance, and gone to their supervisor and said, this is really what we're doing and how, this lays it out. So other things chaplains do. I mean, one chaplain I spoke with said he goes around with these Russian, I think they're called kupi dolls, which is a doll, and inside's a doll, inside's a smaller doll, inside's a smaller doll. And he says to patients and to staff, and especially with staff, he says, a patient this is an African-American chaplain. He said, a patient may look like an angry, fat black man, he said to me, but if you open it up, inside is another person. And inside that's another person. And inside that is the person's soul. And we need to realize and remember that in each person, even though we may be turned off for them for whatever reason, black, white, whatever, fat, thin, angry, whatever, that, there's a person there, and to keep that in mind. So again, I thought, what a wonderful idea, what a wonderful sort of image, and sort of having these tangible, literally go around with this sort of Koopy doll. So again, I think these are lessons that other chaplains and other providers can use.
Yeah,
Marty,
and I
go
just
ahead.
wanted to call on Marty, but before that, I wanted to say I worked at a hospital with zero chaplain presence during
Yeah,
COVID.
yeah, yeah,
And I
yeah,
can tell you the glaring chasm
yeah,
of a gap that we had because chaplains are so integral and so vital. And to have that void, especially during a time during COVID, was horrible. And as palliative care, I ended up stepping in and doing small mosaic projects with all the different floors because no one had anything else to offer except a phone number, a 1-800 phone number. And now we have a beautiful mosaic, a tree of life that all the nurses, doctors, chaplain, we ended up getting a chaplain at the very end, and staff created as a dedication to the lives lost and the
Wow.
tragedy of COVID. But I am not a chaplain. I just was attempting to pull everybody together. But Marty had a comment.
Yeah, it's related a little bit to what you just commented on. In your most recent paper, you talked about boundaries and you talked about being able to say no. And it made me think, what does it take to say no? And I have had chaplain colleagues share with me commentary about that feeling like, in your own words, widely ignored or dissed or marginalized. And one quote struck me in particular, and it says, "Do we as chaplains take on more because we are trying to prove our worth and struggle to say no?"
Yeah, so thank you for that. Yeah, so I published a paper, and thank you for that, Marty, about boundary issues that chaplains face. The good news is that chaplains have freer time in a lot of ways than physicians or nurses do. Physicians often have 8 or 11 minutes per patient, whereas and less on rounds sometimes. Whereas chaplains have more freedom to say, well, I'll sit down with this patient, needs me for an hour or an hour and a half. And yet chaplains face issues, one in how much time to spend with patients, but also then after patients are discharged, some patients call the chaplain and say, look, I'm now in a nursing home. Could you come and visit? Or I'd like to continue the relationship. I feel closer to you than I do to my clergy at some church that I rarely go to, or synagogue or temple or whatever. And so chaplains need to figure out how to draw boundaries, and that's often hard to do. They're not trained to do that. So in psychiatry, as a psychiatrist, there's a long tradition of very much respecting boundaries. It's 50 minutes. What do you do when the patient calls you other times? How do you deal with that? You need to discuss it because some patients are very needy and will, kind of use as much of your time as they can get. And that may not be, you need to have a work-life balance is one. You also have several patients, so you need to figure out how to divvy up your time, and boundaries are difficult to maintain, but could be very important. So chaplains struggle with this, I think. I think it's something that my understanding is not really taught in chaplaincy in terms of, when do you end a relationship? When do you, end a visit? Another chaplain said that when she was a trainee, she was working with an older chaplain, and they went into a patient's room, and the patient had just died, and the family was all there. It was a young patient, and the family were crying, and the chaplain speaking to me, who at the time was a trainee, said, I thought we'd turn around and leave. The chaplain came in on the chaplain, and clearly that's not where their head was. But this older chaplain said she just sat down on the floor, and the trainee did the same, and they waited. And the family, eventually, maybe 20 minutes, half hour later, the family, I want to say calmed down, but they gotten a point to which actually having the chaplain there turned out to be incredibly helpful. And the older chaplain sort of knew that. But again, how do you know how long do I stay? A lot of this are lessons that one learns with time, wisdom, if you will. And so, I saw the research as partly, collecting those kinds of insights. I asked chaplains, what do you know now that you didn't know in the beginning that's been helpful for you? And a lot was around these boundary issues. But they are marginalized. One chaplain said, I have to decide what ditch I want to die in. Do I want to stand up to the doctor and say, look, I think this is what's going on? Chaplains also find medically valuable information. I mean, one chaplain said there was a man who came in with abdominal pain, got $1 million workup. They found nothing. 6 months later, came back with abdominal pain, got $1 million workup. They found nothing. Several months later, came back, and the chaplain said, let me talk to him. And the chaplain said, well, when did the pain start? And he said, well, January 19th, 2019. And the chaplain said, what happened then? And he said, well, my wife died that day. And no one had sort of put this together, that this was what was going on. And so chaplains, I think, often do find medically valuable information, but they're sort of ignored by physicians. Like, you don't know what you're talking about. You're the chaplain. And so I think there needs to be more of an appreciation of these issues. And I think that's a problem.
Caitlin, go ahead.
I'm sorry, I certainly don't want to monopolize the conversation, but I'm thinking about what you just shared and thinking about the kind of essential role in healthcare of chaplains as story collectors and
Yeah.
story. And so one thing that I have been working on with colleagues is thinking about the moral distress of chaplains,
Mm-hmm.
because often we are the last line.
Yep. Yep.
And there's no real
Yep.
place for
Yep.
our moral distress. So
Yep.
one thing that we have started to do is to take these stories that we hear from patients, from our support services folks, doctors, from nurses, and find institutional places to engage in storytelling.
Yep.
So one thing we're working on is hearing the stories of our environmental services teams.
Yep.
And taking those stories to the place of administration, because
Yep.
we've built the relational capital. We care for them as well.
Yep.
And our research is different. Our research is ultimately about story collecting and
Yep.
storytelling, which is a different kind of research than we usually encounter in healthcare. And I have found that that has been an incredible way to address moral distress.
Yep.
Because we don't have a lot of power in the system. We have a lot of capital and a lot of stories.
Yes, well, that's wonderful that you're doing that. And again, I think what's interesting to me is that chaplains often on their own in different institutions are coming up with creative ways. Like Rachel was talking about mobazelak, for instance, kind of people to creative ways of working in this space. And I think sharing them is very important, because there may be chaplains, I'm sure there are chaplains, I know there are chaplains at other institutions that would love to do something like that and just haven't thought of it, perhaps, or et cetera. So I commend you for that, and I encourage you in that. That's wonderful. I would say one small thing is that stories can be part of qualitative research. That is that there is qualitative, sort of ethnographic, sort of anthropological research that looks at stories and analyzes them, and there are very sort of rigorous ways of doing this that one can learn to see what are the common themes. So there may be people in environmental services who each has their own story, but there are certain common themes, how they're perhaps unappreciated, how doctors don't really know what they do, patients don't know what they do, administrators don't know what they do. And so I think that, you could also publish this in academic journals or other kinds of publications to sort of get the word out. Obviously, if some of this is, if it's research, you need to get IRB approval, but that's possible to do. But I think communication is key, but also communication between people at different institutions. So I think getting the word out, here's something we did that was very helpful. I'm sure that people you interview and speak to are thrilled to have their story be heard. Often these are people who are voiceless. And so you're giving them voice. I mean, I find that even that chaplains in many ways are the voices for the voiceless in hospitals, often people who literally can't speak and get ignored, and no one tries to communicate in the chaplainal part, because I think chaplains are trained to have a sense about the importance of the dignity of each person, of each individual. They'll spend the extra time with a person who can only communicate by pointing to letters, let's say, because whatever their vocal cords aren't working or something. So these are very important services, and thank you for sharing that.
Yeah, I think all this work is so important to highlight, and it's really important for all clinicians in all roles to remember that when we cultivate empathy, even if we haven't become the patient, if the doctor hasn't yet become the patient, if we can imagine being in that other person's shoes and try to see things from that perspective, it just makes all of us more empathetic and more caring and giving more personalized care to those patients. So yeah, are there any other questions? Oh, Marty, hi.
I don't often get to to get to meet a lot of ethicists and ask a question about Immanuel Kant. So I'm going to take advantage of this opportunity. Wouldn't things just be easier if we all felt like Kant and removed the emotions and just thought with pure reason? And none of this would be an issue. We wouldn't have to unpack the cognitive and the emotional pieces. Of course, I say that all tongue in cheek, of course.
Yes, right. So uh, I would say a few things on that. So one, oh, if it were possible, right? So we do have emotional selves, and that could be a great thing or it can be a problem. The problem, of course, is that our emotions can bias us. So we may think, oh, that's a
Mm.
XYZ person, so I'm going to ignore that person. And chaplains actually do an important role overcoming biases, I should say. So there's stories in the book. Um, you know, patient comes in, and the staff says, "Oh, she's just a drug user," and ignores her because she's been here before and wanted drugs. And the chaplain realizes, no, there's something different this time. And it turns out she has a, life-threatening medical illness that the staff just ignored because they said, "Oh, that's XYZ person. She's just a drug user, so we'll just ignore her." Uh, so, um, so as you're right, what the Kant is the one who articulated, or among the who've articulated most strongly, the fact that we owe, a sense of duty to each person, that each person is entitled to a certain set of rights and respect. So that is very much a Kantian notion. So absolutely. Uh, Morals, though, and morals can get in the way. So there's a sort of yuck response that there are people who say, well, the word morals comes from the same Latin root as the word mores, and the word ethics is from the same Greek root as ethos. So our ethos and our mores are sort of our morals and ethics, which means at a primitive level, what we see, what everyone is doing is what we should do. So if everyone is, no one's wearing a bikini when they're going to the theater, everyone's dressed up, you should be dressed up and not wear a bikini going to the theater, for instance, or whatever. Whatever you may wear at a nude beach, you're not wear is something you're not going to wear at a, walking down the street. Or, we don't eat with our hands. If you go to restaurants, you don't eat with your hands. Uh, you know, maybe if you're home, you don't have any forks, you might stick something with your hands, but you don't do that in public. So, but similarly, people will say, well, at one point, people said, oh, well, for people to live together and be intimate before they got married, well, that's yuck. Or people of different races or different religions to get married, well, yuck, because it wasn't familiar. It's not what's done, so it shouldn't be what's done. So people have this sort of emotional yuck feeling that leads them to make moral decisions that instead we should be making a logical argument about. In other words, here are two individuals, they're both adults, they have the right to do what they want, they're not hurting anyone. If they want to live together and get married, even though they're different religions, like, who cares? I mean that's their right, even though it's not may not be what was familiar in 1930 or whenever. That's today, we accept that. So we need to be careful of our emotions. On the other hand, motions can be forces for moral good. We may see that, the Me Too movement or Black Lives Matter. We see that there's an injustice in the world, and we feel passionate about it. We see patients. Many of us see patients being treated badly, or whomever in the world treated badly, or see homeless people and feel that's a bad thing, and we sort of get people feel, let's not just walk by the homeless person, but that bothers me at an emotional level. Let's support a candidate who's going to help them, or let's contact the whomever, the health department or the police department, or try to get services, or et cetera, et cetera. So, we evolve with a set of emotions. They could be, and I think they could be used for good or bad, morally and ethically, and we need to sort of analyze them and how we respond, and use them for good, not bad. But great question. Thank you.
Really great questions, really great dialogue. Caitlin also has a comment that said she believes healthcare institutions could invest more deeply in spiritual care in order for frontline chaplains to be able to do the qualitative research and still be able to respond to the overwhelming need for care of patients, families, physicians, teammates, etc.
Yeah, very important point. And Rachel, I was struck earlier. You said that you worked in a hospital that did not have chaplains, and unfortunately, about a third of hospitals do not have chaplains. And many of those that do have chaplains have local volunteer clergy, which is better than nothing, but they often only know about their particular religion. So it may be a whatever their background is, they know about that religion. They don't know anything or much about other religions or feel comfortable talking to people about other religions, and let alone people who have no religion. And they also aren't trained to help patients with end of life issues. So chaplains hopefully pick up some of the medical terminology. If a person says, stage 4 versus stage 1, that what that means in terms of end of life issues, et cetera, for cancer or something. So it's important that more institutions have chaplains. I was struck why the institution had no chaplain. I mean, if you have a sense of that, do they never
They
have
had
one?
they had one, a student chaplain in place, and then I think they had graduated. I'm not sure all the details, but they had graduated, and then they were looking for the permanent one, and then the pandemic hit, and we were still sort of just waiting for a while. It was challenging.
I see some comments in the chat. I don't know if there are any questions here or things I should talk about. If anyone wants to raise their hand or other questions.
Well, and I'm also struck by the variety of topics that you've done so much research on. So I want to encourage our audience to take a look at a lot of your papers and your books, because you've really covered a wide breadth of knowledge and a wide variety of perspectives with your background as a doctor, but also with all your academic work and that sort of thing. I think you have a really varied perspective, and I really appreciate that.
Thank you. Yes. Well, I try to take a sort of humanistic perspective, if you will. And I draw quite a bit, not exclusively on qualitative research as I method, as I mentioned, because I think it fills in the gap. So on this issue, for instance, people have attempted to show quantitatively that if you saw a chaplain or not in the hospital, that when families later fill out those, are you satisfied with our
The
service?
survey.
5 surveys, that there's a correlation. And one study showed there was, and the next study showed that there wasn't. And of course, the reason is because chaplains are more likely to see people, as you all know, who are close to death than dying. So many the patients they see die. If the family fills out a satisfaction form a month later, how satisfied are you, 0 to 5? Families may not say, oh, 5, it was a great experience, right? But that's why I think that actually looking at what chaplains do, and there are other studies that show what do chaplains do. Well, 60% pray with the patient and 30% give social support. That is just scratching the surface. That's important, but to know that they mediate, to see the kinds of ways that they help staff, as they say, the kind of that they invent rituals. I mean, these are all, very helpful, concrete things that just mark down 5 things they do, do they pray or not, isn't going to capture. And I think that it's important to capture these other elements of how chaplains, patients, providers lead their lives, because it's about how we lead our lives, and
Yeah.
those
It
things.
sounds like you're proposing another study.
Oh, I
A
absolutely.
more in-depth study, so we can
I think,
better capture all
yeah,
the work that chaplains do, I think.
yes, exactly. That would be great.
We would love to collaborate with you on that. That sounds really good.
Great.
Well, if there are no further questions, I'd like to thank Robert very much, Dr. Klitzman, for being here. We really appreciate your wisdom and your perspective and your papers and your books. And thank you all to the audience for being present. Oh, hi, Caitlin. You got one more thing to say? Go ahead.
I think it's a waving hello, like a goodbye, hello wave, not a hand, but maybe I'm
Okay,
wrong.
it's a goodbye, perhaps. Anyway, we greatly appreciate your time. Thank you so much. And everyone have a beautiful Friday. Thank you.
Thank you. Bye-bye.